Atherosclerosis, lipid lowering agents এখানে শুরুতে আছে হচ্ছে atherosclerosis, premature or accelerated development of the atherosclerosis is strongly associated with elevated concentration of certain plasma lipoproteins, especially the low density lipoproteins by LDLs that participate in cholesterol transport. A depressed level of high density of lipoproteins is also associated with increased risk of atherosclerosis. তাহলে হচ্ছে এরকম ব্লাড ভেসেলসের ভিতরে কি প্লাক তৈরি হবে, স্ক্লেরোটিক প্লাক ফর্মেশন হবে। নাও প্যাথোজেনেসিস, রেগুলেশন অফ plasma lipoprotein levels involves a complex interplay of dietary fat intake, hepatic processing, and utilization of the peripheral tissue. Primary disturbances in regulation occurs in a number of genetic conditions involving mutations in the apolipoproteins, their receptors, transport mechanisms, and lipid metabolizing enzymes. Secondary disturbances are associated with fatty diet, many endocrine conditions, and disease of the liver or kidneys. Treatment strategies: diet should be devoid of cholesterol and saturated fats and trans fats, high carbohydrate, alcohol. It raises triglyceride and very low density lipoprotein by VLDL levels, and rich in fibers and omega-3 fatty acids. 2 number, drugs. For an individual patient, the choice of drug treatment is based on the lipid abnormality. Lipid lowering agents, classification of the lipid lowering agents একটা হলো competitive inhibitors of high molecular HMG reductase inhibitors by strains, clovastatin, atorvastatin, pravastatin, pravastatin, simvastatin, rosuvastatin, pitavastatin. Niacin বা নিকোটিনিক অ্যাসিড, ভিটামিন B3, ফাইব্রিক অ্যাসিড ডেরিভেটিভস বা ফাইব্রেটস, আমাদের আছে জেম ফাইব্রোজিল, ফেনোফাইব্রেট, বেজাফাইব্রেট, সিপ্রোফাইব্রেট। বাইল অ্যাসিড বাইন্ডিং রেজিন্স, তাহলে কি বাইল অ্যাসিড পিত্ত, গলস্টোন, এখানকার যে অ্যাসিড আছে বাইল অ্যাসিড বাইন্ডিং রেজিন্স, এর মধ্যে এগুলোর মধ্যে আছে কি কোলেস্টিপলস, কোলেস্টাইরামিন, কোলেসেভেলাম, inhibitors of intestinal sterol absorption, azitamine. Major pathways involved in the metabolism of the chylomicron synthesized by the intestine and VDRL synthesized by the liver. তাহলে হচ্ছে কাইলোমাইক্রন সেটা সিনথেসিস হবে কোথায়, ইন্টেস্টাইন, আর VLDL এটা হচ্ছে লিভারে। তাহলে এখানে ইন্টেস্টাইন, ডায়েটারি কোলেস্টেরল প্লাস ডায়েটারি ফ্যাট ইন্টেস্টাইনে আসবে, কাইলোমাইক্রন ফর্মেশন হবে। লিপিল, LPL, কাইলোমাইক্রন রেমন্যান্টস, এখান থেকে LPL, HL, এখান থেকে তৈরি আসবে অ্যাপোই মেডিয়েটেড, অ্যাপোবি, এগুলো মেডিয়েটেড হবে। তাহলে ফ্রি ফ্যাটি অ্যাসিড, কাইলোমাইক্রন থেকে ফ্রি ফ্যাটি অ্যাসিড, এটা আবার হচ্ছে পেরিফেরাল টিস্যুস উইথ LDL রিসেপ্টরস, এখানে অ্যাডিপোজ টিস্যুতে যাবে ফ্রি ফ্যাটি অ্যাসিড, LDL, VLDL, IDL, LPL, HL, LDL, লিভার remnant receptors, LDL receptors. Mechanisms of metabolism of lipoproteins of hepatic origin. RER, ApoB, ApoE, ApoC, cholesterol, mevalonic acid, HMG-CoA reductase, acetyl-CoA, cholesterol synthetic pathway, lysosome, Golgi vesicle, blood, capillary endothelium, B100, VLDL, LDL receptor, LDL lysozyme, cholesterol esters, HDL free fatty acid, VLDL receptor. Now, mechanism of action of anti-lipid drugs. Blood, LDL, VLDL, B100, hepatocyte, acetyl-CoA, HMG-CoA are cholesterol niacin, HMG-CoA reductase inhibitors, azitimib resins, gut. Terms of interest: lipoproteins, macromolecular complex in the blood that transport lipids. Apolipoproteins, proteins on the surface of the lipoproteins, they play critical roles in the regulation of the lipoprotein metabolism and uptake into cells. Low density lipoprotein, cholesterol rich lipoprotein whose regulated uptake by hepatocytes and other cells requires functional LDL receptors, and an elevated LDL concentration is associated with atherosclerosis. Terms of interest: high density lipoprotein by HDL, cholesterol rich lipoprotein that transport cholesterol from tissues to the liver. তাহলে এটা হলো কোলেস্টেরলকে টিস্যু থেকে কোথায় নিয়ে যাবে, লিভারে। Very low density lipoprotein বা VLDL, triglyceride and cholesterol rich lipoprotein, triglycerol and cholesterol rich lipoprotein secreted by the liver, তাহলে এটা লিভার সিক্রেট করবে, that transport triglycerides to the periphery. It is precursor of LDL. HMG-CoA reductase, 3-hydroxy 3-methyl glutaryl coenzyme A reductase, 3-hydroxy 3-methyl glutaryl coenzyme A reductase, enzyme that catalyzes the rate limiting step in the cholesterol biosynthesis. Terms of interest: lipoprotein lipase by LPL, an enzyme found primarily on the surface of endothelial cells that release free fatty acids from triglyceride in the lipoproteins. The free fatty acids are taken up into cells. Proliferator by activated receptor alpha. Proliferator activated receptor alpha, member of a family of nuclear transcription regulators that participate in the regulation of the metabolic process. Target of the fibrate drugs omega-3 fatty acids. Omega-3. HMG-CoA reductase inhibitors by stains that are most effective and best tolerated agents for treating dyslipidemia. These drugs are competitive inhibitors of HMG-CoA reductase, catalyzes an early rate limiting step in cholesterol biosynthesis. Statins were isolated from a mold Penicillium citrinum. Now, pharmacokinetics. After oral administration, intestinal absorption of the statins is variable. Variable 30 to 85%. There is extensive fast-track hepatic uptake of all statins, mediated primarily by the organic anion transporter OA, organic anion transporter OATP1B1. The T-half of the parent compounds are 1 to 4 hours, except atorvastatin and rosuvastatin, which have half-lives of greater than 20 hours, and simvastatin with half-life of greater than 12 hours. It is metabolized by CYP3A4 in liver. Mechanism of actions of statins. Statins exert their major effect through a mevalonic acid like moiety that competitively inhibits the HMG-CoA reductase, reducing conversion of HMG-CoA to mevalonate, thus inhibit an early and rate limiting step in cholesterol biosynthesis. Reduced hepatic cholesterol synthesis results in increased expression of the LDL receptor gene and increases the synthesis of the LDL receptors. The greater number of LDL receptors on the surface of the hepatocytes results in increased removal of LDL from blood. Degradation of LDL receptors also is reduced. Other effects of stains: endothelial function, stains and plaque stability. Endothelial function, statins and plaque stability. Endothelial function improves endothelial function of the independent of changes in plasma cholesterol levels. Statins and plaque stability. Statins inhibit monocyte infiltration into the artery wall and inhibit macrophage secretion of the matrix metalloproteinases, which degrade extracellular matrix components and thus weaken the fibrous cap of the atherosclerotic plaque in vitro. Other effects of statins. Statins are the effects গুলোর মধ্যে আছে inflammation, lipoprotein oxidation, statins and coagulation. Inflammation. Statins decrease the risk of chronic heart disease and levels of CRP, an independent marker for inflammation and high chronic heart disease risk. Lipoprotein oxidation. Statins reduce the susceptibility of lipoproteins to oxidation both in vitro and ex vivo. Statins and coagulation. Statins reduce platelet aggregation and reduce the deposition of platelet thrombi. In addition, they have variable effects on fibrinogen levels. Adverse effects. Mild elevation of serum aminotransferase are common but are not often associated with hepatic damage. Patients with pre-existing liver disease may have more severe reactions. An increase in creatine kinase released from skeletal muscle is noted in about 10% of the patients. Severe muscle pain and even rhabdomyolysis may occur. অ্যাডভার্স ইফেক্টের মধ্যে আরও আছে HMG CoA reductase inhibits the metabolized of COP3A4 drugs or foods that inhibits its activity, risk of hepatotoxicity and myopathy. তাহলে hepatotoxicity তৈরি করবে। Because of evidence that the HMG CoA reductase inhibitors are teratogenic, these drugs should be avoided in pregnancy. Time of intake: hepatic cholesterol synthesis is maximal between midnight and 2 a.m. Thus, statins with TF life will get less equal 4 hours. All about atorvastatin and rivaroxaban should be taken in the evening. Niacin বা nicotinic acid, pyridine 3 carboxylic acid. Niacin is a water-soluble B-complex vitamin that acts as a vitamin only after its conversion to NAD or NADP, in which it occurs as an amide. Hypolipidemic effects of niacin require larger doses than are required for its vitamin effects. Niacin is the best agent available for increasing HDL-C 30 to 40%. It also lowers triglyceride by 35 to 45% and reduces LDL-C levels by 20 to 30%. Niacin is also is the only lipid lowering drugs that reduces LPA level significantly. Lipoprotein A, lipoprotein A, lipoprotein A is a compost of low density lipoprotein particle that has a second apoprotein in addition to ApoB100. Niacin mechanism of action: niacin and related compounds may exert their effects on lipolysis. তাহলে এগুলো কি লাইপোলাইসিস মানে লিপিড ভাঙাতে এগুলো কি করে ইফেক্ট দেয়। ইনহিবিটিং কোন এনজাইমকে ইনহিবিট করার মাধ্যমে অ্যাডিপোসাইড অ্যাডিনাইল সাইক্লেজ এনজাইম। In adipose tissue, niacin inhibits the lipolysis of triglyceride. Adipose tissue ক্ষেত্রে niacin inhibits the lipolysis of triglycerides by hormone sensitive lipase, which reduces transport of free fatty acids to the liver and decreases hepatic triglyceride synthesis. Adverse effect: niacin adverse effects হচ্ছে the most common medically serious side effects are hepatotoxicity, তাহলে লিভার এখানে hepatotoxicity তৈরি হবে, manifested as elevated serum transaminase and hyperglycemia. Flushing and dyspepsia limit patient compliance. Flushing and pruritus of the face and upper trunks are prostaglandin mediated. Skin rashes and acanthosis nigricans, dry skin, a frequent complaints. Patients with history of peptic ulcer disease বা peptic ulcer disease should not take niacin because it can reactivate ulcer disease কে পুনরায় অ্যাক্টিভেট করতে পারে। আরো niacin আরো অ্যাডভার্স ইফেক্টের মধ্যে আছে in patients with diabetes mellitus, তাহলে diabetes mellitus এর ক্ষেত্রে niacin may induce insulin resistance, can cause severe hyperglycemia. It also elevates uric acid levels, তাহলে এটা কি করে ইউরিক অ্যাসিড লেভেলকে আরো এলিভেট করে and may reactivate gout. Niacin at doses used in humans has been associated with birth defects in experimental animals and should not be taken by pregnant women. Bile acid sequestrants, cholestyramine and cholecephalam. They are oldest of amongst the hyperlipidemic drugs and they are probably the safest because they are not absorbed from the intestine. Now, mechanism of action: bile acid sequestrants are highly positively charged and bind negatively charged bile acids because of their larger size. তাহলে এগুলো সাইজগুলো কি অনেক বড় হয়। They are not absorbed, তাহলে বের হওয়ার কারণে এগুলো কি ইন্টেস্টাইনে কি অ্যাবজর্ব হবে না। and the bound bile acid are excreted in the stool এবং স্টুলের মাধ্যমে কি এটা বের হয়ে যাবে। নরমালি তাহলে স্টুলের মাধ্যমে এটা বের হয়ে গেল। নরমালি more than 95% of the bile acids are reabsorbed, so interruption of this process depletes the pool of bile acids and hepatic bile synthesis increases. decreased hepatic cholesterol content, stimulated production of LDL receptors, have an effect similar to that of the statins. Adverse effect মধ্যে আরো আছে bloating and dyspepsia. It induce increase in bile acid production, which is accompanied by an increase in hepatic triglyceride synthesis. Ingestion of the chloride salts, rare instances of the hyperchloremic acidosis may happen. Ingestion of the chloride salts, rare instances of the hyperchloremic acidosis may happen. They are available as a powder that must be mixed with water and drunk as a slurry. Interference with the absorption of many drugs, including some thiazides, furosemide, propanolol, L-thyroxine, digoxin, warfarin, and some statins. Fibric acid derivatives. Fibric acid derivatives on fibrates, gemfibrozil, fenofibrate, bezafibrate, ciprofibrate. Mechanism of action of fibrates. Fibrates are ligands for the peroxisome proliferator activated receptor alpha. Peroxisome proliferator activated receptor alpha, PPAR alpha. Protein, a receptor that regulates transcription of gene involved in the lipid metabolism. PPAR alpha অর্থাৎ peroxisome proliferator activated receptor alpha expressed primarily in the liver. তাহলে এটা প্রাইমারিতে কোথায় হবে? লিভারে। and brown adipose tissue and a lesser extent in kidney, heart, then skeletal muscle. Fibrates reduces triglyceride through PPAR alpha mediated stimulation of fatty acid oxidation. Now PPAR alpha increases synthesis lipoprotein lipase by adipose tissue, which associates with capillary endothelial cells and enhances clearance of the triglyceride rich lipoproteins. And clearance of triglyceride rich lipoproteins. A reduction in hepatic production of ApoC3 serves as an inhibitor of lipolytic processing and receptor mediated clearance and enhance the clearance of VLDL. PPAR alpha stimulation of ApoA1 and ApoA2 expression increases HDL levels. Now, azitimib is a product that is converted in the liver to active glucuronide form. But converted to active. This activate metabolite inhibits luminal cholesterol uptake by jejunal enterocytes. Jejunal enterocyte এটা হচ্ছে কি করে? ইনহিবিট করে by inhibiting the transporter protein NPC1L1. Reduce delivery of intestinal cholesterol to the liver by chylomicron remnants, stimulates expression of the hepatic genes regulating LDL receptor expression and cholesterol biosynthesis. Now uses azitimib uses as monotherapy. Azitimib reduce LDL cholesterol about 15 to 20%. When combined with an HMG-CoA reductase inhibitor, it is often more effective. The actions of azitimib are complementary to those of statins. Statins inhibits cholesterol biosynthesis, increases intestinal cholesterol absorption, and azitimib, which inhibits intestinal cholesterol absorption, enhances cholesterol biosynthesis. Adverse effects মধ্যে আছে azitimib adverse effects মধ্যে আছে other than rare allergic reactions, specific adverse effects are not been observed in patients taking azitimib. 2. The safety of azitimib during pregnancy has not been established. 3 number হলো azitimib is available as a 10 mg tablet that may be taken at any time during the day with or without food.